Based on the chapter pages provided in the images, here is a breakdown of the key clinical protocols and guidelines for denture insertion. 1. Pre-insertion denture inspection. Before insertion, inspect three main areas: tissue or fitting surface, check for imperfections, nodules, sharp edges, and residual plaster. Borders must be rounded with no sharp angles, Fig. 13.1. Polished surface, smooth without scratches, free of plaster on the gingival crevice. 2. Denture insertion and adaptation evaluation. Evaluate complete dentures sequentially during insertion. Adaptation and pressure indicating paste, PIP. Check adaptation to tissues individually while asking the patient about pain or discomfort. Paint PIP onto the tissue surface using a stiff bristle brush. Seat the denture with pressure applied to the first molar areas on both sides. Remove after 1 minute and inspect the tissue surface, Fig. 13.2. Complete removal of paste, high pressure spot, needs trimming. Brush streaks remaining, no contact. Other areas may have excessive pressure. Paste remaining with no streaks, proper contact. Verify frenal areas and posterior palatal seal for necessary relief, Fig. 13.3. Borders and peripheral extensions. Evaluate and correct borders for overextension after individual adaptation is confirmed. Retention and stability. Evaluate retention and stability individually. Note, lower dentures are generally less retentive than upper dentures. Retention improves over a few days as soft tissues adapt. 3. Occlusion and correction. Causes of occlusal discrepancy. Occurs even after lab remounting due to errors in jaw relation records or mounting casts. Tissue changes since impression taking. Differences in tissue adaptation between record bases and processed bases. Real F effect, resiliency effect of supporting tissues. Correction methods. Intraoral correction uses articulating paper placed bilaterally, Fig. 13.4. Disadvantages: can mark non-occluding areas due to saliva, movement, fails to mark foci properly, and soft tissue displacement masks premature contacts. Alternative: occlusal wax placed bilaterally, Fig. 13.6, can pinpoint high spots more accurately. Extraoral, clinical remounting, recommended. Advantages: better visibility of occlusion from all angles, including lingual, eliminates soft tissue resiliency, provides a stable foundation without shifting bases, and reduces clinical chair time. Procedure: fabricate remount casts by blocking undercuts, Fig. 13.7, and pouring plaster on the tissue surface, Fig. 13.8. Mount maxillary cast using face bow transfer, Fig. 13.9, and mandibular cast using an interocclusal check record, Fig. 13.10. Selective grinding, bull law, apply bull law, grind buccal cusps of upper teeth and lingual cusps of lower teeth, Fig. 13.11, for centric and eccentric corrections. Polish trimmed areas afterward. 4. Patient instructions. Insertion and removal. Insert upper denture first, larger and more retentive. Remove lower denture first. Tongue position. Train the tongue to sit forward, resting against the inside of the lower denture flange and front teeth to stabilize the mandibular denture, Fig. 13.12. Eating and speech. Eating. Start with soft, non-sticky foods cut into small pieces. Chew slowly on both sides simultaneously. Avoid biting with front teeth until posterior chewing is mastered. Speech. Practice reading aloud and repeating difficult words to adapt to palatal bulk and altered saliva flow. Tissue rest and hygiene. Tissue rest. Remove dentures at night to prevent soreness, candidiasis, and bruxism. Brushing. Clean over a container filled with water to prevent breakage if dropped, Fig. 13.13. Brush gently with a soft denture brush. Soaking. Use commercial cleansers, Fig. 13.14, or a DIY solution, 15 cc household bleach plus 4 cc Calgon plus 115 cc water. Soak overnight in white vinegar to decalcify calculus deposits. Never use hot water. 5. Recall and denture adhesives. Recall schedule: first recall, 1 to 3 days. Second recall, 1 week after first visit. Third recall, 3 to 4 months after second visit. Maintenance, every 1 year. Denture adhesives. Indications: compromised retention, xerostomia, neurological disorders, resective oral surgery, severely resorbed ridges, or temporary security during jaw record taking. Contraindications: improperly fabricated or ill-fitting dentures, known allergies. Application: apply small 1 cm beads or 5 mm spots on the dry tissue side of the denture, Fig. 13.15. Do not over-apply. Always clean off completely daily. Based on Chapter 14, Post-Insertion Problems, here is a complete summary of the causes, presentations, and treatments for post-insertion complete denture complaints. 1. Primary etiologies of post-insertion inaccuracies. Problems typically stem from minor errors accumulated across various fabrication stages. Border molding, open mouth technique, fails to establish vertical dimension and support to muscles, causing overextended denture flanges. Jaw relation recording, inaccurate record bases, flabby, displaceable ridge tissue, deforming existing dentures, excessive, unequal registration pressure, or patient TMJ, muscle tone issues. Mounting, improprieties in record base seating, heel interference on casts, or improper keying of occlusal rims. Laboratory processing, tooth displacement during processing, flasking distortion from incomplete closure, acrylic overheating during polishing, warpage, and acrylic shrinkage. 2. Looseness, loss of retention and stability, a decreased retentive forces. Lack of peripheral seal, underextended borders, depth, width, caused by improper border molding or tooth arrangement affecting the distobuccal maxilla and lower buccal shelf, Fig. 14.1 and 14.2. Treatment. Apply soft tracing compound to borders and reprocess with resin. Incorrect posterior palatal seal, PPS, underextension causes general looseness, overextension causes looseness while talking, insufficient depth causes looseness while eating. Treatment. Re-evaluate junction with mobile soft palate, re-perform border molding in PPS, and reprocess. Inelasticity of cheeks, seen in aging, scleroderma, or submucous fibrosis. Treatment. Border mold incrementally with functional movements. Air beneath impression surface, caused by deficient impressions, damaged casts, warped bases, over-trimmed undercut areas, Fig. 14.6, or excessive relief. Treatment. Identify with PIP and reline, remake if rotational paths or severe fit errors exist. Deep undercut ridges may require soft liners. Xerostomia, caused by diabetes, drugs, atropine, phenothiazine, menopause, radiation, vitamin deficiencies, or sialolithiasis. Treatment. Use artificial saliva substitutes, coatings, no glandular function, or pilocarpine, sour candy, some glandular function. Poor neuromuscular control, caused by improper denture shape, tongue control failure, or motor neuron disorders. Treatment. Ensure polished surfaces occupy the neutral zone, Fig. 14.7, train tongue position, duplicate old dentures if the patient is accustomed to their shape, or use adhesives. B. Increased displacing forces. Causes: overextended borders, Fig. 14.8, occlusal prematurities, non-coinciding MIP and CR, Fig. 14.9, placing posterior teeth too far posteriorly, non-anatomic teeth, Class 2 skeletal cases, or an incorrect occlusal plane, Fig. 14.10. Treatment. Trim borders using PIP, Fig. 14.11, perform intraoral, clinical remount occlusal corrections, remove second molars if tuberosities cause an improper occlusal plane, or reset teeth. C. Support problems. Causes: fibrous displaceable ridges, lack of ridge height, or bony prominences. Treatment. Relieve bony prominences, use denture adhesives for poor ridge scenarios. 3. Discomfort and pain. Primary location, cause. Etiology. Management, treatment. Impression surface. Sharp acrylic nodules, unrelieved undercuts, overextension, deep post-dam, sore throat, swallowing difficulty, or lower knife-edged ridge. Locate with PIP and trim. Apply permanent soft liners for knife-edged ridges. Polished surface. Thick distobuccal flange interfering with coronoid process during opening, yawning, or side-to-side movement. Identify with PIP while patient performs border movements, Fig. 14.12 AB, and trim. Occlusal surface, functional pain. Premature contacts or lack of balanced occlusion. Selective grinding using articulating paper, occlusal wax. Lingual to lower anterior ridge. CR and MIP do not coincide, causing a slide. Perform selective grinding to make CR match MIP. Labial lower ridge, incisive papilla. Insufficient incisal overjet or excessive vertical dimension, VD. Trim labial aspect of lower anteriors. Remake denture if VD increase is greater than 2 mm. Cheek, lip biting. Insufficient posterior overjet or decreased VD. Round posterior upper buccal cusps or reset lower incisors to improve incisal guidance. Tongue biting. Teeth set too far lingually on lower ridge. Remove lower lingual cusps or reset teeth. Clinical note for ulceration. Advise patient to leave denture out for 1 day to allow ulcer healing. 4. Poor appearance and aesthetic complaints. Causes: incorrect occlusal plane orientation, improper vertical dimension, improper labiolingual, labiopalatal positioning of anteriors, or decreased labial fullness, causing corner creases. Management. Extensive aesthetic changes are difficult without remaking. Minor VD adjustments may be attempted. Emphasizes proper try-in consent. 5. Miscellaneous problems. A. Speech problems. Sibilant S. Errors. Tooth contact on S, caused by increased VD or excessive overbite. Difficulty pronouncing S, caused by excessive overjet, Fig. 14.13. Bilabial P and B, labiodental F and V, errors, caused by incorrect VD and anterior incisor position, e.g., upper anteriors placed too far back, Fig. 14.14. Management. Most speech problems settle over a few days as the patient acclimates. Persistent errors require remaking. B. Clattering of teeth. Causes: increased vertical dimension, increased incisor overlap, loose dentures, cuspal interference without balance, or porcelain teeth. Treatment: identify and correct underlying etiology, e.g., adjust VD, balance occlusion. C. Altered taste. Dentures do not cover most taste buds. Taste issues usually relate to acrylic thickness, reduced thermal conductivity. Remaking with a metal base enhances thermal conductivity. D. Nausea and gagging. Anatomical, mechanical causes: loose dentures, poor occlusion, thick distal termination of upper denture, palatal placement of upper posteriors, low occlusal plane, overextended retromylohyoid area, or underextended denture borders causing saliva accumulation. Psychogenic causes: refusal to swallow due to fear of aspiration. Treatment: eliminate mechanical causes, prescribe atropine plus mild sedatives initially, or refer to psychiatric care if psychogenic.